So I'll invite Dr. Abby Jacob for the next talk. Dr. Abby Jacob will be talking to us on comparison of medical management versus SLT in newly diagnosed POAG. So SLT has rekindled the interest of a lot of people in the last few years in view of the publication of the light trials. Even the long-term light trial results have been published, and they've been published from the UK. So we have a person from UK itself to actually speak to us about it. Dr. Abby, please.
Good afternoon, everyone. It's a pleasure to be here. Thank you, Karan. Can I just ask by a quick show of hands, does anyone treat primary open-angle glaucoma or ocular hypertension as with SLT as a first choice? Anyone here? Okay. So that's a good start. It's wonderful to make a great diagnosis. Very happy with this one because this publication made the cover of the journal. So you can make these fancy diagnoses. The next thing is to decide what you're going to do, because we tend to give them drops, same as you. I mean, not very different. But we all know that all these side effects are there, and we are sort of committing our patients to a lifetime of miserable eyes. It's a horrible thing to be using drops. So we know that compliance with glaucoma medication is poor, okay? 90%. And these are studies from countries where, by and large, the cost of the drug is taken care of. Here, our patients have to go and buy the damn thing without insurance and things like that. So, lots of non-adherence, and there are so many reasons for non-adherence. And that, on the side, is a list that one of my lovely old ladies brought to me. Okay, that's a list of medications that she's on. And just about everything is an eye medication. Okay, and she has had it off and on, but she has been diligent enough to make that list. And I got that. I said, oh, I need to take a picture of this. So we all know also about SLT. It's not new. SLT has been used several times. For several years. Mark Latin is the one who popularized it. By and large, the shift from ALT to SLT has happened. So it's not something that is new, but nobody is using it. Side effects are hardly anything. These days, when I do an SLT, I don't even give the patient any drops or anything. Just tell them to take a paracetamol or a ibuprofen if they have to. But by and large, most people don't have a problem. And I'm sure you guys all know about the modulating effect of SLT on the trabecular meshwork, unlike ALT that causes a burn. And it gives a good result. It gives a drop in intraocular pressure quite similar to latanoprost. Okay? And these studies were already there before light. I'm coming to light. Again, we also knew that there was hardly any problems with side effects, and we also got a good drop in the intraocular pressure over time. Okay? So, why are we not doing it? And that's where this proposal came to the NIHR. It is a big study. £2 million was spent on the study. I was lucky enough to have reviewed the paper from the NIHR. But this was done by Gus Gazzard and his team at Moorfields, 6 centers. And they randomized 718 patients into 2 groups, 362 with the drops and 356 with the SLT. And they use a strategy of having a target pressure and then treat the patient appropriately to get that target pressure. And they looked at the intraocular pressure effects, the control of the disease as monitored by all the tests that we do for glaucoma, and the requirement for surgery. And the interesting thing was 72% were at target IOP. It is 11 patients that went in for surgery, all from the medication group, none from the SLT group. And they also had, the NIHR model has a lot of cost calculation, and they also found out that it costs In our terms, 458 pounds less per patient at 3 years. So here are some of the results. Again, you can see that there's about almost 30% drop in pressures, but the most important thing, I think, is that reduction in the number of trabeculectomies. And then, of course, there is that reduction in pressure in progression between the two groups as well. The other interesting thing is the fact that the laser group had, very good control without any medications. A good number, 78%. Similarly, the evidence is now out there. They've come up with a follow-up paper for 6 years, and it shows that 70% are staying drop-free. And the other very interesting thing is that this study, I mean, not exactly, but it has been reproduced in Tanzania. Okay, that's a graph of the other side. But here they couldn't compare it with latanoprost because latanoprost is not freely available in Tanzania, so they used timolol. And again, good results. So our NICE got into action because there's 458 pounds to be made per patient. Okay, so they have changed their recommendations for the treatment of chronic open-angle glaucoma. The definition is funny for NICE. It is not pure POAG, it's also pseudoexfoliation and pigmentary glaucoma, which makes it a bit tricky. And even for ocular hypertension, now the recommendation is that you offer them SLT, not necessarily treat them with SLT. Okay, so I, sitting in my clinic, I do talk to them about SLT, but I don't really offer them SLT because I know that if I put them on the waiting list for SLT, it takes them about a year to get the SLT. So I have to start them on some sort of a drop, and then we have that discussion later on. Everyone else has also gotten to the act. That's the European Glaucoma Society, American Academy of Ophthalmology. So everyone's recommendation now is to offer laser trabeculoplasty as the first treatment for open-angle glaucoma. The problem with this is very simple. I mean, we know about all this. The problem lies there. When you have to do SLT, what it means is that you have to have someone who knows the angle to do the SLT. You can't leave it to the, in all clinics, you get the junior most person to do all the dirty work, okay? So this is time consuming, a bit tiring to perform. If you hold your hand up there and keep doing an SLT, it's not easy. And if you have a whole list of SLTs, by the end of it, you'll have neck pain. So I can see why it's not very popular as a first line of treatment, even in places where they can do SLT on day one. Okay? But that problem could be solved. Okay? Enter the Eagle from Belkin Vision. So this is a new machine that doesn't have a contact lens. Okay? Tick. 2, it applies a laser in a very short period of time. It applies 120 spots all around the limbus. And unlike the traditional SLT, which does the laser from the mirror on the body, so this one applies direct. That's the big difference. The system has an eye tracker, so eye movements are taken care of. It's a touch screen. It's a very advanced scanner, so I think as a spin-off from that, you'll get better scanning technology. Oh, thank you very much. I didn't know that. Okay, and therefore, it is, I think, going to take over if they get their marketing right. The problem is, even though they say it is non-contact and no contact lens, you have to have a speculum because we all know that you can't see the superior limbus if you just have a patient staring at you. But they have also gone ahead and done the studies to prove the efficacy and the safety of DSLT, as they call it. Pretty good results, comparable with SLT. So very advantageous. And therefore, you now have a dilemma on your hands. And that is, you have this option here where you can put them on drops and give them all these problems, or you can opt for this. The problem with DSLT is that it's quite an expensive machine. And to make matters worse, their marketing strategy is one of these. They are one of these companies that want you to pay per treatment you do. So it's a bit of a racket going on there. I'm sure it'll all be sorted sooner rather than later. But this is down to you, and you need to make the choice for your individual patient. Thank you very much.
I'm sure inquiries for the SLT machine will spike after this presentation.